Thanks for having me. I thought I'd like to build a little theme around more evidence about the existence of tethered cord syndrome and occult tethered cord syndrome in the Chiari patient. It will be a little bit of an overview of the literature, but also part of my talk will be to steal some of the evidence what we have learned in the pediatric population about the occult tethered cord syndrome without radiographic evidence, so to say, quote unquote, and then also that said that we are basically dealing with a syndrome with little or no radiographic evidence. There are some similarities to the idiopathic normal pressure hydrocephalus syndrome, just that was discussed decades ago, and with the guideline process and also with prospective multi-center trials, we had provided better standards in the care and the management of the hydrocephalus cohort, and I'd like to share the experience, and hopefully we can translate this into some of our things that we're going to do in this group here about the Chiari patient. So it all comes down to how much we believe, not so much that we have to believe it, but how much we can provide evidence to the caudal traction theory. And when I scrolled through the literature, I found that there were actually two papers, one earlier and one later, that could evidence by serial imaging that Chiari had been acquired by a lipomatous phylum. These are case reports, one from Ellenbogen, where they had observed a patient with an asymptomatic fatty phylum, and then later on also discovered Chiari malformation, and another one by Dr. Spiros Zgouros from Greece, where he also found acquired Chiari in a child with split cord malformation that then disappeared after thickened phylum division. So, and then also this group around TUPS in earlier studies, even though at the end that was an MRI study where they just compared conus level versus tonsillar ectopia in a number of Chiari patients, and then they found that there was no degree of the level of the conus and the level of the tonsillar ectopia, and then they argued that this speaks against the so-called traction theory. But then also what they found, and I don't know why they hadn't been more attentive to this finding, that those that had lower conus level, like borderline low, they had syrinx associated with their Chiari, whereas those where the conus was not borderline but higher, they had no syrinxes. So that again speaks to it. Then how we can approach this. So we should probably look at the literature where there was real tethering. And there's actually a nice paper published by Valentini, which you're going to connect me to her, where they looked at the risk of tethered cord for the Chiari malformation in a review of 110 patients, or a large series. And they stated that really after detethering of lipomas or lipomyelocytes, there was no change in the conus level actually. Though there were, in those patients that had Chiari and tethered cord, which was present in 70% of the patients in those series, there were some patients where the symptoms with the low-lying tonsils after detethering stabilized, but still a number, 30% of those patients needed Chiari decompression after the lipoma was taken care of. So why I'm bringing this up is more or less to just kind of see what we find that either supports or disapproves our caudal traction theory. We also should not forget to look at Chiari and myelomyosarcoma. Don't shoot me. I know these are different entities. But I think we could learn something from what we observed there. Of course, the MOMS trial and showing that the fetal repair had significantly reduced the prevalence of Chiari in spina bifida shows that there's truly a theory that the brain, probably due to loss of spinal fluid in the spinal canal, is under traction. And that was Mark Luciano this morning elaborated a little bit about the hydrodynamic theories. But when we look at patients later, when spina bifida patients are in their teenager age, and we sometimes have to, of course, we follow for scoliosis, syringohydromyelia, we would not argue against the fact that we first would detether the spinal cord, then go on after the Chiari. So this should make us think, and there is something to the management sequence and algorithm that we can learn from when we look back at how we manage Chiari in myelomeningocele. Let's now go to the next step. So what's out there about this tethered cord syndrome and occult tethered cord syndrome in Chiari? And one of the, I guess, most earliest paper, I might say, that were discussing the concept of treating Chiari by sectioning of the phylum was a study by this group where they looked at 20 patients, and they had Chiari patients with phylum, tight phylum, and after sectioning of the phylum, there were rise of the medullary conus, and then also in those patients where this has been done, the symptoms associated with the Chiari malformation had disappeared. So this, again, some evidence and some move towards that. And of course, the paper from Dr. Millerud and Bolognese and Dr. Kula was then, and still is, one of the most important papers that did show that sectioning of the phylum in Chiari patients associated with tethered cord syndrome changed the position of the conus and also changed a lot of other dynamics, which they had shown by intraoperative ultrasound. And this is kind of a seminal paper, I want to say, that had stimulated the debate and encouraged further studies. And what I like to point to what here also Dr. Millerud and his group has done, they also included patients that had no radiographic evidence of low-lying conus or fatty phylum, and they established somewhat criteria in the dimension of urodynamics, neurology, and also limb findings to support the diagnosis of occult tethered cord in Chiari. But we'll go also back to the pediatric literature, which has also some good proposals out there how to establish this better. After Millerud's paper was published, there were a couple of papers that were trying to work against it, I might say. And forgive me for using maybe not the right words here, but there was a review article by Massimi and Di Rocco where they kind of reviewed what's been published to support or disapprove the occult tight phylum syndrome. And they concluded that the literature so far cannot support the caudal traction theory. But mainly because they found that there is no experimental evidence, and they were citing Tubbs' work where they looked at cadaver studies where they were kind of pulling on the spinal cord and were seeing whether this leads to traction or downwards displacement of the tonsils, which did not show positive, though you might not disargue with me that cadaver models have a problem in itself since the tissue consistency and plasticity certainly is different. They had done some MRI studies in non-human primates where they did MRI in the sitting and in the standing position, in flexion and extension, and didn't see a change of the conus. So you might argue, well, non-human primate and humans, how can you compare that anatomy? Then yesterday night, when I was working on a lecture, I found this image, and I was thinking there might not be such a big difference as we speak. But yet, I think there's more to it. I think that in all respect to Tubbs, but now we have better MRI modalities and they're with more functional aspects, and we might want to revisit the potential of looking at primates and position of conus. and hydrodynamics. So I'm glad that Dr. Ashley Koch had really summarized the evidence of the tethered cord syndrome, or summarized this paper on the evidence of association of Chiari malformation and hereditary connective tissue disorders. And she proposed a nice scheme of looking at a genetic profile and maybe by that way stratifying the positive and the negative. And I guess, as you said, Alison, this is so far not just the only, but also the most important paper we have in this regard. Dr. Henderson, of course, supports that concept, and we all agree with him, that certainly if we think of Chiari and hypermobility, we should also think of tethered cord. And yesterday I had a nice discussion with Dr. Henderson where it's probably more, not so much the anatomical problem, but more like a deformity of the tissue and the deformity of the neural elements with the hypermobile spine that might also affect the phylum pathology. And I hope that you're going to look probably also at patients with the tethered cord syndrome in the EDS and look at the genes, right? Because that would be the next step. So, but we have other genetic syndromes, and I never get it right to say what the factual syndrome is, but as you know, one of the features is the imperforated anus, and here, we also have evidence that, particularly in those with imperforated anus, and there was a publication by a Japanese group that there is association of fatty phylum, tethered cord, and Chiari. And this is a patient of mine that I treated 2 years ago, where I started with a sectioning of the phylum. However, she later actually needed also Chiari decompression, but yet that was more out of imaging concern, I hate to say, because this girl was developmentally so delayed that it was really difficult to figure out whether, all her mental problems and motor problems are due to those anatomical problems. So that is hard in syndromes, of course, to establish clinical criteria. But this brings us down to the management. So the chicken and hen question, how are we approaching those? Of course, Dr. Bolognese suggested if there is tethered cord syndrome, if the clinical symptoms speak to the fact that there is tethered cord, based on the neurological findings and the symptoms, one should section the phylum, but there is no consensus that which way, whether we would decompress a Chiari or do tethered cord decompression. As I just said, we have to figure out the chicken and the hen thing first, but there is a nice study published in 2011 where the authors actually reviewed, by David Frim, reviewed the pertinent literature, and in the abstract they have the literature citation, which I find kind of interesting. They were discussing that since most of the patients that still need Chiari decompression based on the literature, despite sectioning of the phylum, that you could do that in the combined setting, and they advocated for a safe same-day surgery for Chiari decompression and sectioning of the phylum. So I think when we look at the pediatric population, I might say, and we can discuss this, they have probably a much clearer scheme of proposing how to approach occult-type phylum syndrome, and there is, and that can help us also to stratify this syndrome for the Chiari patient in prospective studies. The first seminal paper on the occult was by Webby, and I don't want to spend too much time on this, but they were the first that identified some criteria for the occult phylum syndrome, and they had sectioned the phylum even in patients without or little radiographic evidence, and they had quite some good outcome in sensory abnormalities. Pain improved, weakness improved, though the improvement of fecal and urinary incontinence was variable. Later on, more things were published in the occult tethered cord syndrome, and recently Steinberg, and you might help me, but he published in 2013 a nice review and said that we still have to learn more of the natural history, whether those patients ultimately benefit, and he was thinking of a clinical trial that is currently underway, but I don't know whether anyone is aware of that. Paul Steinberg actually had initiated a trial. But that was what he indicated in his paper, that we need prospective evaluation of that. When starting as a pediatric neurosurgeon in Rhode Island Hospital, certainly I had to come across questions and patients with a suspicion of occult tethered cord syndrome. And this is illegible, but it was meant to, because I was going to show 3 cases where I think they show the extremes of this and how vigilant we should be about that syndrome and the clinical characteristics. So these were actually 10 patients, not 11, where we are now reviewing all these things a little bit more thoroughly, but where we were looking at the cutaneous signs, neurological signs, urological signs, orthopedic signs, and of course all had normal lying conus or borderline low at the disc space of L2, L3, and then no fat in the phylum, maybe a thickened phylum, 2 millimeter, or some tiny, what Dr. Kobe has shown this morning, fat if you just look long enough at the MRI study, but not much. And this was a challenging case. Actually, that boy was screened with for a dimple. So the pediatrician had done an MRI, surprisingly, at 6 months of age, because she felt that dimple is kind of concerning. And then there was a conus at L2, no fat in phylum, and there was a syrinx. And I hate to say, but when that kid came to see me, I'd made the diagnosis, it's most likely idiopathic syringomyelia. Now you're really going to shoot me. But then after 2 years, I kept watching that kid, and there was some subtle increase in the syringohydromyelia, but then also the kid became symptomatic. There was increased lower extremity tone, leg tightness, and some equinovarus deformity when the kid started to run, but not after resting. Parents felt not potty trained with some accidents. I couldn't convince in a 2.5-year-old kid, it was also a hyperactive child, so our urologist wasn't really thinking that urodynamic studies would help, so we went by the syndromes, neuro plus uro, and did the surgical detethering, and that was a success. Despite, and that is the point, no change in syrinx and no change in conus level after 6 months, which might not be the longest outcome span, but patient is improving, more active, no tripping and falling anymore, no urinary accidents, and the mom felt that the kid has overly matured and wasn't that ADHD type anymore, which brings us back to the cognitive things. That is interesting, because all the literature that I was starting up with that look at is there change in the conus or in any of the elements, there might not need to be any change. So we should be a little bit more open-minded about whether we really want changes or need changes in the imaging. And whether this is a criteria of the outcome or ultimately proves our concept. It might not. It might be the wrong way. This is a 1.5-year-old female, no cutaneous signs. The neurologist found gross motor delay. She was not walking, but she found low muscle tone, which she would not expect at that age. And there was also some slight scoliosis and torticollis. There was syringohydromyelia. Where is it? Yeah, well, you can see it, oh yeah, syringohydromyelia here, sorry, and then borderline low-lying conus, no fat and phylum. We did surgical detethering given the concern, and she walked 3 months post-surgery. The scoliosis improved in the 1 year post-imaging, but stable syringohydromyelia and no change at the conus level. But you saw improvement in the scoliosis. And the last case was a very challenging case. This was a patient that was referred to me by the GI colleague who had who couldn't do anything about the constipation that was worsening. There was a sacral dimple. There was some clumsiness when we examined this kid and reviewed the neurological history. I should say that all other issues of constipation had been ruled out. No Hirschsprung, no other things. So the GI colleague was at the end of the road after a good year of trying to figure it out. So there was some intermittent urgency, but usually associated with when the child was on the toilet and was pressing and was having stress with his constipation. Again, urodynamics not feasible. There was also some growth plateau. The kid was seen by endocrinology, but there wasn't any irregularity there. So an MRI was done by that colleague, and conus at LT2/3, no fat, no syringohydromyelia, but according to some criteria, which I show in the next slide, that were established, there were 3 clinical qualifiers. Low-lying conus, we sectioned the phylum, the falling spells, the accidents had gotten better, and this kid dramatically caught up with growth all of a sudden, so no surprise. Again, no change in conus level at the 6 months MRI. So in the pediatric literature, there is actually some definition, it's in the textbooks, about that cutaneous signs are not mandatory, but you should have, in order to establish the syndrome, at least 3 of the 4 clinical qualifiers. If you have only 2, there should be some evidence in the imaging which is progressive or stable severe syringohydromyelia, or a phylum a little bit thicker, but this is already argued also against it. So the myth of idiopathic syringomyelia has to be considered, and it's probably not an idiopathic syringohydromyelia because it might be proven otherwise. So how accurate can this clinical syndrome be? And how can we approach that clinical syndrome? And what I said initially is I want to merge to, because that's what we have, to a different topic from my own experience with the idiopathic normal pressure hydrocephalus guidelines. Why I'm picking idiopathic hydrocephalus, not just because I have done work there, but actually that's what it was also from the get-go. It was a clinical syndrome with elements in the range of gait, incontinence, and dementia. There was little radiographic evidence, of course, large ventricles or ventriculomegaly, but as you know, we always get back the reports from the radiologist that it's in the range of atrophy or age appropriate or whatever. And then when we shunt them, despite no change in the ventricles, they get dramatically better. So we have a syndrome that gets better with intervention without radiographic evidence. And what we did in the guidelines, we were approaching it with evidentiary work and seeing what are the symptoms and the tests that really most reliably and accurately define and support that syndrome. And just want to mention that this was a work that was headed by our fearless leader, Dr. Anthony Marmaru, who passed away in 2010. We were so lucky that we had him to help. And what we found at those days in 2000 is that when we reviewed the literature, that everything what was described for that potentially supports the syndrome was class 3 evidence only, so only expert opinion, single case, serious case studies, very poor evidence. So that was then a big cry for prospective trials. You might say, oh yes, of course it would be, and you know, you don't need to tell us this. But I have to say that definitely since I hope I can say that, since the guidelines have been published, there are more prospective trials there, because once the word was out, people understood that we have to answer questions prospectively with randomizing some of our tests and no longer, and also do multi-center collaborations and no longer just report single-center results. So what we did for the first time in NPH, and that might be something that we might want to adopt or take, is we defined probable versus possible, unlikely in the diagnosis of INPH. And again, I apologize that it's not legible, but we looked at what brain imaging might help to classify probable versus possible versus unlikely using our literature evidentiary work. And then also we looked at clinical findings that are most supportive of the syndrome and then also of outcome to shunt treatment. For example, decreased step height, decreased step length, and then also the cadence, walking speed, turning, and all these features. And also we looked at cognitive tests. So we picked elements which are most frequently reported and then classified them and ranked them whether this speaks to possible, probable, and unlikely. I think this is a step that has to be done before, and before we go into trials, before we do all sorts of studies, as also Dr. Ashley Koch said yesterday, we need to have criteria out there that helps us to stratify our patients and our syndromes in different degrees of clinical certainty. And that is the first step that needs to get done. And then you can kind of come up with a diagnostic algorithm, which we did also for the guidelines, where you'll see what tests are out there that shift our clinical certainty towards a success of treatment to higher percentages. We found out at the time of the guideline that the triad and the imaging proves like has a predictive accuracy of 50% shunt success, and then when you add CSF dynamic tests or drainage protocol, the certainty for improvement increases. But this is long outlived, this algorithm, because people started doing more things about it. And actually, busy slide, but that's what happened then, and this is only one example, and forgive me if I'm showing my things here, but then all of a sudden we understood all of the tests needed to evaluate it prospectively. And what Tony Marmaru said, you know, for example, the high volume TAP test that had been used as a routine, and people had been excluded based on no response to a high volume TAP test. So Marmaru said, you know, that you can't do that. You have to randomize patients. What we did identify probable and possible NPH based on the guidelines. We did the TAP test, but also patients, so all patients were shunted regardless of the result of the TAP test. And we found out that we did cognitive studies before and after the TAP test to give it a more robust evidence of change, but the changes that we saw in our cohort are minimal. Most of the patients only changed by 5% before and after TAP test, which leaves us with no idea how we can, you know, ultimately use that as a predictor for shunt treatment. Rarely you see the great change in the TAP test, and actually we found that we would have missed 2 out of 3 patients that are candidate for shunt treatment if we had excluded them based on a negative TAP test. So our conclusion that we were allowed to make after a review was that you cannot exclude patients based on a negative TAP test. This study would have not been done before the guidelines were published because people felt that it's not necessary. And we do have, and that gets me to my last 3 slides. We do have published data, again, going back to the pediatric community, and I might have missed some studies, where there are positive clinical symptoms that we can look at and that we can use if we want to go the same road. For example, what this group said, they said that they had patients with occult tethered cord syndrome with no radiographic, non-diagnostic spinal imaging, and they underwent sectioning of the phylum, and then 14 had urodynamic testing, and they underwent postoperative neurodynamic testing. 5 of these demonstrated objective improvement postoperatively. And then they say patients presenting with abnormal findings in at least 2 categories were most likely to improve following untethering. And those with abnormalities in only 1 category had lesser response. So you can rank, degree of clinical certainty based on clinical categories. And another study, and I hope I'm interpreting them correctly, already end of 90s, said that neurodynamic studies are important, but not all people have pathologic neurodynamic studies, so you also have to look at other test modalities that might support our syndrome, and that's what we have to evaluate prospectively. So to summarize, what I'm thinking is certainly I hope I could make the point that from the pediatric literature, there is some more evidence that, in fact, we are dealing with a syndrome that is supported by categories of symptoms in the ortho, uro, and neuro dimensions, and also probably cutaneous signs, and that this will hopefully also help us to identify the tethered cord pathology in Chiari and also hereditary connective tissue disorders. And that will help us to move forward with guidelines to establish criteria for OCTS based on evidence literature review and consensus processes, just as we did with the INPH guidelines, and then we could move on to prospective clinical trials that support clinical and imaging criteria for OTCS with and without Chiari, or Chiari with and without OTCS. What I find interesting, and that would be a research project that I wanted to do, is we started now, for example, in our craniosynostosis patients to look at fetal ultrasounds and to see whether there is any evidence of abnormality, whatever that might be. But maybe we should also review, if we can, these days, fetal images and pathology in all those cases to see whether there's something in there that might help us to get some more evidence of what's happening in terms of failure. And then also, people have done so, and there's so far one paper that looked at phylum pathology, but we should maybe look at features of the taut phylum. For example, Dr. Bolognese in his study has shown that the nice phylum that was pushed against the dura and was taut. But in those cases, for example, in my surgical experience, it's not always that taut. Sometimes you fish it out in between the cauda fibers and section it, so we don't always have that. So maybe this also might help lead us to going back, even this seems like old stuff to do, but looking at the phylum. And for example, here, this is the patient with no syrinx. You see fat in the phylum, and this is a patient with significant syrinx, case number 6, where you don't see any fat, but you see like infiltration, inflammation, and some corked collagen fibers that might help us to also understand a little bit more about the anatomy of the phylum and how that relates to the clinical syndrome that might add to our understanding. Thanks very much.
Paula, you had a question?
Yeah, it's just a couple of points regarding the article you were quoting by Miraj about tethered cord. First of all, I have to apologize on behalf of our group. That article was very ponderous and not extremely clearly written. There were too many things, too many ingredients, too many messages were through, and ended up being a hard-to-read article. So the take-home messages of the article were the following. Number one, most of the patients that, a large chunk of the patients we're dealing with were having connective tissue disorder. And instead of the thick phylum terminale, we're finding phyla terminale which were much thinner than normal, and we're having a different thing. So instead of being a thick rope, we're a very tight rubber band, number one. Number two is, at no point in the article it is said that we were supporting a pull from below syndrome. The article describes two categories of patients. Patients with tonsil herniations of two parts. Tonsil herniation beyond the category, the standard 5 millimeter thing, with the volumetrically small posterior fossa that, all the people in the room would agree that is a classical Chiari 1 malformation. And other patients in the second category of patients with the normal volume of the posterior fossa, therefore with a normal cisterna magna, with no crowding of the posterior subarachnoid spaces, and minimal tonsillar displacement, something like 2 to 3 millimeters. In this category, we saw that cutting the phylum, the tonsils went up. So the one point of the article was tonsillar herniation not always is a synonym of Chiari 1 malformation. Certain patients in which there is a normal posterior fossa and the tonsils are down but not that far, sometimes this is a pull-down theory, but those are not Chiari patients. Those are minimal tonsillar herniation which is not coming from the posterior fossa, another thing. You wouldn't think twice with a normal posterior fossa of lumbar peritoneal shunting from below to indicate that as a culprit. So unfortunately, the article was written in such a way that probably breaking down the article in many different spots and just focusing on this subpopulation the message would have been more clear. But one of the take-home messages was that typical Chiari and tethered cord sometimes occur together, but without a cause and effect relationship with each other. And we were saying, all right, we do the Chiari decompression, and we do the surgery for that. And if the patient has reasons for the detethering from the waist down, we do the detethering for the tethered cord syndrome, but not to treat a tonsillar herniation. Because for the Chiari, for typical Chiari, the cause of the Chiari would be the volumetrically small posterior fossa squeezing the thing out. So unfortunately, all these things were kind of buried in so many lines. The article is about 14 pages long. So many level of details that everything got shuffled. And everybody cried wolf afterwards saying, okay, this is an article that like Roy Salvador is proposing the pulling from below syndrome. Reading carefully is far from that.
Quick question for you. Any comments about retethering and how to avoid it? And one other question that I've always wondered about, many of us who've sectioned the phylum see that the phylum rises up. Does that ever translate into putting traction on the nerve roots that now take up the tension that was previously protected, in a sense, by the phylum?
Well, I mean, the main complication of retethering, that's what we see that in the more complex, like lipoma or myelomyelin. I usually try to close the neural tube, like do a neuralation in order to prevent, rarely a patch, because I don't see any evidence that had been voted favorably. And the retethering risk in the simple phylum, I think, is pretty low according to literature. Not quite sure about the track. You're thinking if there's evidence that the nerve roots change when you. What the only data that had kind of tried to give mechanistic evidence to us, I think these are cadaver studies, as far as I.
Certainly, Amada did some work many years ago on that.
One of the points was that the dental ligaments dissipate part of that traction, so you have less distortion in the nerve root than you would expect.
Thank you very much. Any other questions?
Just ago. A couple of quick points. I know you didn't want to emphasize the mom's trial because we're looking at Chiari 2s there, but when we do the in utero repairs, the kids are still very much tethered throughout pregnancy and when they're born. So I don't, although, yeah, sure, we disconnect the plateau temporarily, I still think those kids are tethered. The fact that they are born with a lower prevalence of Chiari 2 malformation could speak to a lot of things, like changes in cerebral hydrodynamics and so on, but probably, at least to my mind, not a tethered phenomenon, since they're still tethered. They're all tethered.
Yes.
The other point is I'm worried about our specificity when we're defining this syndrome clinically. Very worried about that because the symptoms that are included in this syndrome are extremely nonspecific, especially in a pediatric population. So in the cases that you showed, which I think were very thought-provoking, but there's a 3-year-old who has incontinence. Well, lots of 3-year-olds have incontinence. Is that really pathological? I think 30% of 5-year-olds have incontinence. In the normal population, when you screen the population, 18% of teenagers have back pain. So we're looking at these incredibly common, incredibly non-specific symptoms. I mean, again, a 1.5-year-old who's not walking yet, that's actually pretty common. The 3-year-old who has a clumsy gait, that's pretty common. The natural history of a clumsy gait in a 3-year-old is that it's going to improve in the vast majority of cases as the kids age. A natural history of very benign minimal scoliosis is actually quite good as well. So we have a problem with these incredibly common symptoms that are not specific for any particular neurological disease that have, in general, excellent natural histories. And we're combining 2 or 3 of those and saying we have a syndrome that we can't define by any other objective measure. And so we're on thin ice, obviously, really thin ice there, unless we can somehow define that better. And then, but nevertheless, thought-provoking presentations. Thank you very much. And the last point I'll make, again, getting to the natural history. The natural history of a fatty phylum in the normal position is excellent for most people, right? And you mentioned retethering after the surgery. We used to think it was nothing. At least I always used to think it was nothing. But now, increasingly, when you look at the fatty phylum surgical series that have been coming out over the last decade, there is actual real symptomatic retethering in some of these cases, even when the surgery was done by certain groups for asymptomatic individuals. Varying between 5%, 6%. One group, I think, was 8%. Which seems high. But even let's say it's the low number, let's say it's 2% or 3%, that seems to be worse than the natural history in many cases. So at any rate, just thank you for the presentation. Some problems, I think, with the syndrome itself.
Thanks for the comments. I totally agree with you on the thin ice. That's why we have to get better evidence. And I appreciate your comments. Thanks very much.
Thank you, Carmen.
One last question. Yeah, great talk, Petra. Just a comment. Do you have any experience with prone MRI for difficult to identify tethered cords? I've seen an article, I think.
Yeah, I also scrolled through that article, and I have no personal experience with that. I'm just wondering, that's certainly an interesting study to look at it. When I mentioned like Tubbs' work on the primates and look at various MRIs, but I wonder whether we will find that consistently, given that we're not always having that taut phylum, so there might be other components to the phylum pathology than just like a positional thing. And back to Dr. Henderson's comment about more tissue deformity that we cannot see on the MRI.
Thank you.
Thank you very much.